So my name is Elizabeth Streams, and today we'll be talking about medication pump technology. I have nothing to disclose. And so the objectives of this seminar are to describe the history of medication pump technology, analyze and critique published literature. It says clinical trials, so for the accreditation of the survey, we're keeping, or of the CE, we're keeping the same objectives, but we're really going to be looking at published literature, examining the safety and efficacy of medication pump technology, evaluate UVA's historical and current use of medication pump technology, and identify the projected future use of medication pump technology. So infusion pumps are synonymous with any medical infusion device that are used to administer IV medications to patients. So that includes volumetric pumps, syringe pumps, cassettes or cartridges, and really their main function is to control infusion rate and volume limits. And as we know, they have a range of alarms with adjustments. So an overview of medication pumps in the 70s was the development of what we're now calling dumb pumps, and we'll go over each of these in the next slides, but just to kind of give you an overview of the timeline. And then in the 1990s was the development of what we now call smart pumps, followed by the development of wireless smart pumps in the 2000s, and then in the 2010s we now have intelligent pumps. So we'll kind of break down the differences between the different categories over the next subset of slides. So like I mentioned, the dumb pumps that we are now calling dumb, but really at the time they were innovative and really new to IV medication use and really brought a lot of safety features from what we were previously using. So they brought the development of flow rate, so the large volume pumps had the ability of running things from 0.1 to 999 milliliters per hour. Syringe pumps had the ability of running things from 0.01 to 100 milliliters per hour, and then the epidural pumps had the ability of running things from 0.1 to 10 to 50 milliliters per hour with calibration of tenths of a milliliter, or for the syringe pumps a little bit further down. They also had the addition of patient weights. Flow accuracy was plus or minus 5%. The keep vein opener, the KVO rates were as low as 1 milliliter per hour. The ability to pause or stand by, which was one of the biggest features that was lacking in previous administration use, which we now know is a pretty basic function, but before then it really wasn't anything that was around. And then the alarms, the addition of the alarms, which included the air in line or empty line, the downstream occlusion line, and then low battery. Which again were really things that we take for granted now, and often probably feel like we're being over-reminded that these things are happening, but before then there weren't any functions to really allow users to know that these things were happening to their patients. So some of the issues that, or the errors that were arising with some of these dumb pumps included the fat finger error. So like it suggests, you would push more than one button than you were meaning to push. The screens were, and we'll see a picture in a minute, but the pump itself was pretty, it was pretty easy to push more than one button on some of these pumps. And so an example of this would be morphine being programmed at 99 milligrams per hour instead of the intended 9 milligrams per hour, which, as we can see, would be a huge problem for the patient and a huge error. There was also the units error, so things were being infused in units per hour instead of milliliters per hour, or vice versa. So an example of heparin, which would not be ideal for any clinical situation, would be 26 units per hour being entered into the pump, which is really 0.5 milliliters per hour, instead of 26 milliliters per hour, which is what the intended dose was of 1,300 units per hour. So some pretty significant errors were occurring, and there wasn't really a catch function in it, but keep in mind that there were additional safety features that were available that weren't previously available, so it was kind of a give and take for these pumps. We also there was, we'll talk about that in a second. So drug libraries in these pumps was another function that was new, and it really was a customization of the institutional needs. However, like I mentioned before, there was a lack of the smart features, so it made updating these libraries very difficult. So you had to physically update every single library, and so for an institution like UVA that has a lot of patients and a lot of pumps, someone had to physically go into every room to add a drug or update the pump library, which, as you can see, could be very laborsome and difficult to do. So there also were a limited number of library entries, which also further limited the ability to use this function of the pump. We didn't have any entries for antibiotics, anticoagulants, chemo. We had a handful of high-risk drugs that were entered into the library, but really not using this function to the optimal need or optimal use that added that additional safety level. And so, and then there really, we'll talk a little bit more about why this would be important, but there really was no readily available continuous quality improvement data. So in order to get any information off the pump, if there was a question of was this infused properly, or was there something that happened from the pump, you had to go physically touch the pump, and of course with perishable information that would be something that would be a timely manner and would require somebody to actually go to the patient's room and get the pump. And then you would not be able to use that pump on another patient while you were reviewing it. So it was a problem of resources and limitations of the pump itself. So then, and then another interesting thing to note with sometimes during drug shortages, you're using things that may not be in the pump anyways, but there were times where we were dispensing the pump with the drug, and so you can see that would probably be an additional, not only an additional problem for the pharmacy itself to be dispensing pumps who wasn't usually dispensing the pumps, but also for the nurse and the patient themselves actually getting the pump to the floor would be another issue as well. So a lot of limitations with the dumb pumps, but keep in mind they were pretty innovative at the time. So then we have the invention of the smart pumps, which really introduced the dose error reduction systems, or the DERS. So now we have the addition of drug libraries with soft and hard rate and concentration limits. So a soft limit is a limit that is a suggested max rate or concentration that really questions the user if they are wanting to put the entry in because it's exceeded a limit that we feel is safe for the patient. However, it is overridable ultimately, but it just adds an additional safety feature of, is this really what you wanted to do? And then a hard rate limit or a concentration limit is something that is the max and it's not overridable. We also had pre-programmed initial rates, the addition of tall man lettering, and easier to read screen. So really that extra safety feature with the smart pump itself. There were additional reminder alerts that were added too, so reminding the nurses to double check, requires that telemetry monitoring, central line only, and then there was also the addition of patient or user information being programmable, which is not a feature that was often used and still not fully used. But there were bits and pieces that were added to the smart pumps that made it easier to track certain drugs and certain users in their pump systems. So drug libraries in the smart pumps now are, again, a customization of institutional needs. It had the addition of patient profiles. So at UVA, we use adult, pediatric, and NICU profiles. However, some institutions use med-surg, ICU, whatever have you, of your patient profile that you want to use. The formulary medications are obviously something that we would want in a drug library, but now there were additional features to add additional lines to the drug library. So I mentioned before that there were limitations of not having as many entries in the drug library before. So now this feature really allows you to enter, with the smart pumps, it really allows you to enter much more medications and really more true to what an institution would need formulary-wise. There was also the addition of the wildcard entry. So that's the blank blank that we see, which could be potentially problematic for certain drugs. However, there is also the feature to add concentration limits to the blank blank, so you're not giving somebody full access to fully overriding anything in the blank blank feature. Libraries also have standard administration criteria, so initial and maximum rates, hard and soft limits like we've discussed before, therapy types, so like alteplase for stroke, and then critical alerts. So this infusion should be used for ICU infusion only if you're going to, which we use a lot because we don't have specific ICU profiles other than the NICU profile. So it's just an additional reminder that maybe this drug shouldn't be used in a certain care area. So with drug libraries, it's imperative to work with the pump manufacturers and the clinical experts to ensure safe medication use upon initial implementation. So that was something that the Medication Use Policy Group works with for a significant amount of time last year when we were implementing our drug library and smart pump onboarding. Once it is live, it is important to develop a system to review and modify pump entries as needed. So that's something that we're currently working on now and continuing to work on. And then new drug additions will need to be reviewed by appropriate approved committees. So we use PNT to update our libraries and review our requests, but there are other institutions that use different pharmacy safety committees as well. So what can a drug library tell you? It can tell you if you're trying to deliver a medication outside of the pre-program limits for the drug entity that you've selected in the given profile. However, it cannot tell you if you've picked the wrong drug or profile, if you have a clinical reason to enter something outside of the pre-program limit, if you're holding the wrong medication, or if you are programming the medication for the right patient. So drug library is a great feature, but there are some things still lacking that would require the user to add additional skill or knowledge to. So it's not an end-all, be-all, catch-all, be-all, but it is a great feature to have if you are trying to deliver something outside of the pre-program limit. So there was a UHC query of how other institutions were using their drug libraries, and it included 19 responses. And of those responses, we mentioned earlier that the PNT reviews are drug libraries. So other institutions are using their medication safety committees, their pump oversight committees, or their infusion pump safety committees. And then the question was posed of who owns the library updates, and really unanimously it was pharmacy, but it did range from IT to medication safety officers. So important to note that it is being managed pretty much by pharmacy as a whole. And then the frequency of the drug library reviews ranged anywhere from monthly to quarterly to twice a year to as needed. So really right now what we're doing is reviewing any updated request monthly or as needed through PNT. So some of the examples of limitations with the smart pumps, it does not ensure the 5 rights of the medication, so the right drug, dose, route, patient, and time. It's also essential to use compliance to utilize the functions of the dose error reduction system and the alert. So if you're entering things outside of the features that have been programmed to catch errors, you're really not going to get the functions of the pump, and really limits you to the user errors. And again, it's not really easy with just the basic smart pump. It's not easy to communicate alarms, alerts, or the statuses of infusions in near real time. So then we have the development of the wireless smart pumps, which have two different functions. The unidirectional function is really kind of fading out now, but it's just when the server is talking to the pump, so it can push a library update wirelessly, which is great for getting updates out there. I mentioned with the dumb pumps, that was a really big limitation of having to touch every pump. So now with the wireless smart pumps, you're eliminating that and really increasing the ease of getting drug libraries to the pumps. And then the bidirectional functions is really the server to the pump and then the pump to the server. So that's adding, so you can push your library updates, but then you can also send data back to a central location about the pump. So that's really going to provide information about your alerts and your alarms and really your use of your pumps in general. So it's really enhancing the safety and it allows the review of the continuous quality improvement data, which is an additional function of the pumps that allows you really to dive into your user profiles and what people are doing in real time. So, like I mentioned, it's in-the-moment feedback. CQI data is in-the-moment feedback about pump usage. So it ranges from a variety of things, but it tells you your guardrail compliance or what's being run in basic infusion. So anything that's run outside of a guardrail is called basic infusion. It also shows you your overrides, and then additionally were there reprograms, were high alert drugs overridden, and then were there overrides performed in less than 2 seconds, which would essentially suggest that the overridden warning was not read by the user. And then it can also show you near misses. So that's going to include things that were alerted and then reprogrammed in the pump because of that alert. So, and then this is just an example of our database for the CQI data. You can see that there's a lot going on, and it's a very small picture, but the point of the slide is that there's a lot in there and there's a lot to review, and each time you click into something, it opens something else that you can click into. You could really live in this database. Really, with continuous quality improvement data, it's how are we doing and can we do it better? Which is a function that was really hard to do with some of the previous pumps just because of the limited ability to get the information from the pump to whoever wanted to review it. So some of the limitations with these wireless smart pumps is that most of the pumps need to be powered off to update the library, which you can imagine in an institution like UVA with hundreds of pumps that could require interruption in patient care or just a mass amount of manual labor. There's obviously, if you're using a wireless function, you have the potential to have dead zones and Wi-Fi would be required. There still is the lack of patient or clinician ID, so you're not really requiring the user to enter the patient information or enter the user ID. So that function of tracking who's using what or even what medication is being used in the pump for the patient is not required. And then, or required every time, perhaps. And then with pumps coming in from other institutions, so for an example for us would be like coming in from Augusta, they may not have the same drug libraries that we have, which has created a few problems for us in the past if they're not running on the same system. And then pumps from different patient areas, so patients coming from surgery to the floor may be running in a different profile or a different mode. So they may be in anesthesia mode, which is a smaller library that has less limits, which may be problematic for the safety features that we've tried to instill in the drug library. So then we have the addition of intelligent pumps, which really is an additional feature to the wireless smart pumps in order to close the loop between computerized physician order entry and barcoded medication administration and electronic medical records. So it has the ability to auto-associate the pump with the patient and the clinician or the user, auto pump programming of medications, auto documentation of infusion activity into the electronic medical record, enhanced patient and infusion status monitoring, alarm management, and then really kind of pulling it all together and having an air traffic control or central way to really surveillance the data that is being pulled in and really real-time use. So some of the makes and models, we currently use the CareFusion Alaris pump. I'm sure it is very familiar to most of you. And then there are several other models, such as Baxter's and Hospira's. But really all kind of having a similar setup with a central brain, we call it a brain, is the main monitor. And then having other channels associated with specific drugs, so and the ability to add certain channels as well. And then, of course, we have our famous makes and models with McDreamy. That is not our current smart pump, but a very fun picture. So examples of some of the limitations with intelligent pumps still exist. Obviously, if we don't have adequate drug library development, we're not going to be able to use the functions of the pump, or it could instill further problems with actual correct patient use. So if you're not programming the drug library appropriately, you really, there's the limitation of not being able to appropriately practice potentially. But again, keep in mind that institutions spend months developing these drug libraries, so usually for the most part there are adequate development. There is adequate development. And then lack of standardization. So kind of similar to the drug library development, there is a need for developing a standard practice with the pumps. And then lack of education and training kind of folding into that as well. You really need to be educated on the pump. It is a smart pump. There are a lot of features in it. So you really want to be able to teach your users how to use them and how to appropriately use them. Accountability is another feature. You really need to work with your users to really be accountable for their actions and using the features of the pump to the safest, in the safest mode for the safety of the patient. And then alert fatigue. We all know how many alarms you hear when you walk on the floor because of the pump. So really balancing those alerts and that safety mechanism with really balancing that with the need for medication safety of the drug. So figuring out how to make that balance is imperative as well. So then with the intelligent pumps, we have the addition of interoperability. So it's the ability to combine different information technology systems and software applications to communicate, exchange data, and use the information that's been exchanged. So essentially, when a computerized entry is entered into the system, that will generate an alert to the nurse or the user of the pump, which will then prompt them that they have a dose due, and they will get the medication and then go to the patient's bedside, scan the patient, scan the IV medication, scan the pump. The pump will then auto-generate a medication order and program itself. The user would then review the auto-generation and then start the infusion. And then the pump would then auto-document the infusion data, which would then pull into the electronic medical record, and then the user would validate the system. So it's really taking out a lot of pieces for the user, which in turn increases reliability and decreases user error. So looking at the workflow comparison of pre-interoperability and post-interoperability. So right now, this is worst case scenario, but right now there are about 21 manual keystrokes that are being entered each time a medication is administered. However, post interoperability with that process that we just discussed, there really will only be three needed manual keystrokes. So you can see that that's a huge reduction going from 21 to 3, and really an 86% reduction in manual keystrokes, which again increases the safety of the patient and decreases the potential for errors with the manual functions. So many hospitals do have barcode medication administration systems and smart pumps, but most are not integrated yet. They're also, most IV infusions involve multiple users during the course of therapy, so you're further increasing the likelihood of errors occurring. So from your initial infusion to your dose rate changes, does that get transmitted into the electronic medical record? Who's updating that? How often are they updating that? Really, with the integration of interoperability, it's taking out all of those factors and integrating, automatically integrating that into the system, which is just adding another additional safety mechanism to the patient. So, like I mentioned, we're enhancing patient safety. We're promoting best practice with interoperability. You're going to increase your efficacy, improve your documentation, and then with the integration of interoperability, there's just a plethora of available data and an ability to capture that value practice information. So again, you're not having to go to the pump to see what's happening. It's all pulling into one central location, and someone can review what's really happening and make changes as needed for the drug library and the pumps themselves. So some of the opportunities to improve upon standardizing the following areas with interoperability, so drug concentrations, dosing units, dosing limits, and potentially further preventing fatal overinfusions and underinfusions. And then this picture just shows kind of our current state and really working together with the people, the process, and the technology towards the future state of improved patient care, improved population health, and reduced cost, really using that continuous quality improvement data to kind of cycle through and continue to cycle through moving forward to our projected future state. So how do we increase compliance with the intelligent pumps? I mentioned that that was imperative for the pumps. Some of the suggestions include reviewing the quality, the continuous quality improvement data regularly with a multidisciplinary team. Implement evidence-based limits and monitor compliance, so that kind of ties together as well. Provide ongoing communication to users, including data review and review user feedback. Use data to modify drug library limits and potential need for updates. Review the alarms to reduce fatigue versus need for clinical intervention and action. So we talked about the importance of the balance of that earlier. And conduct direct observational or compliance rounds is actually also recommended to enhance intelligent pump user safety. So that brings us to our first question. Which of the following is true about the history of medication pumps? A, dumb pumps do not provide additional medication safety to patients. Oh, that should be B. Sorry, that messed up. B, smart pumps ensure the 5 rights of medication administration. C, continuous quality improvement data allows institutions to review pump user data in the moment. Or D, drug libraries can prevent the wrong medication from being infused to the patient. Technically B on this slide, C on the paper. Okay, so now we'll look at a little bit of the pump literature that exists. So this literature was a retrospective 1 year before and 1 year after smart pump implementation with soft limits. They really wanted to determine if implementation could reduce IV dosing and administration errors. They found that there was a small reduction in overall dosing errors, but then they found that there was a larger reduction in pump-related errors with the addition of the smart pump implementation of soft limits, or with soft limits. So they went from 41% to 22% after they implemented the smart pump. And there was also a high percentage of post-implementation errors occurring because users did not use the pump software. So really just further, and this was in 2005, so it was pretty new at the time, but just further implementing that, yes, the smart pump implementation with soft limits is providing extra safety and benefit to their patients. The next study was actually a simulation study. So this was really interesting because they were comparing users with traditional pumps, smart pumps, and pumps with integrated barcode scanner and soft and hard limits in both of the smart pumps and the barcode scanning pumps. And so they used patient mannequins that had barcode wristbands and barcoded medications. And they found that the patient ID errors were remedied by significantly more nurses who were using the barcode scanners than with the smart pumps without the barcode scanners or the traditional pumps. So kind of intuitively, if you're giving someone an extra safety tool and really just having them scan something, you would think that that would increase the use of patient ID errors. You're not having to manually enter in the pump what the patient ID is, so you're just giving them the tools to really use that function. So I would hope that that would increase patient ID anyways, but really kind of further driving home the point that yes, this is an additional safety feature that probably should be implemented everywhere at some point. And then they also found that more nurses recognized critical overdose errors when using the pumps with barcode scanners and smart pumps without barcode scanners because they had the hard alerts and the soft alerts, whereas the traditional pumps did not. So again, driving home that point that yes, if you're giving them the tools to be able to catch these errors, they should be catching the errors as well. However, do note that it was a simulated clinical scenario, so it's hard to really implement the true scenario of an ICU or a very busy situation, clinical situation for the user. And then the last study that we'll look at was a prospective monthly review before and after smart pump with barcode and electronic medical record implementation. So they found that their compliance increased dramatically with drug literature usage or drug library usage and integration of the barcode system. And they also found that their pump programming errors related to heparin decreased following the barcode and the EMR implementation. So again, kind of all tying together the point that yes, we are adding additional safety features with these pump functions. So that brings us to question number 2. Which of the following is true about the medication pump literature review? Soft limits may reduce overall dosing errors, especially pump-related errors. Hard limits may help users recognize critical overdoses when programming the pump. C, barcode scanning and electronic medical record integration may reduce medication pump errors, or D, all of the above. All of the above, yes. So looking specifically at our pump use at UVA, some of the current smart pump limitations that we have, they are not assigned to individual patients. They're not associated with intended therapy. Programming does not populate infusion records. We cannot prevent the wrong library selection. It does not intercept drug mix-ups, so the right drug. And there is the potential to infuse discontinued medications. However, in March, we have interoperability coming. So hopefully all of those things will be mitigated by the addition of interoperability. So looking at some of our recent pump usage with the continuous quality improvement data, we had our first official quarterly review since we implemented our smart pumps in April of this year. The quarterly review looked at August to October of this year, and we're still evaluating the best report targets for this data, but kind of going forward, we'll kind of tweak it a little bit too. But looking at the monthly usage, basically overall, we have about 90,000 total infusions in the hospital per month over those 3 months, with about 15,000 basic infusions, so infusions being run outside the guardrails. And you can see that our total guardrail infusions, so our total compliance, which includes everything except for the basic infusions, our recommended target of guardrail compliance is 90%. And so as you can see from the last slide and this slide, we are not at that 90%, with about 15,000 of our 90,000 per month infusions being run in basic. So like I mentioned earlier, this is problematic in that you're not using the safety features that the pump is designed to use with the drug library. So looking at the basic infusions specifically, the top chart is divided into the type of infusion, so primary infusion, secondary infusion, or drug calculated. So you can see that the majority of the basic infusions are being run through primary infusions, and then the bottom is divided into care area profiles. So as we would guess, the majority of the basic infusions are being run in adult profiles, but again, there are the majority of infusions being run in adults just because of the proportion of patients. So kind of scary to see exactly where it all is happening, but it is happening in all of our care area profiles for the most part. So then this is the breakdown of the near misses, which is defined in the next slide. But you can kind of see the different, so these are the examples of errors or near misses of errors because of an alert that was generated through the pump that due to our guardrail libraries, the different types of errors may have been averted because of the alert that was fired. So not a high number, but definitely still happening. So good to know that there are parts of our system that are catching things that could potentially be fatal. And again, occurring in all of our care area profiles. Ooh. So then this is just the definitions of the decimal point error, and then their subcategory of decimal point error, rate dose error, double digit error, high rate error. So they're kind of intuitive, but just in case you wanted further clarification. And then, so the number of total overrides, so it did decrease over those 3 months, but pretty much around 10,000 overrides per month that are occurring, which is a pretty significant number of overrides. And then this graph shows the overridden alerts that were then reprogrammed within the guardrail limit. So it's the percentage of total guardrail alerts where the action taken after the alert was reprogrammed. So again, potentially averting severe harm to our patients. And it is a pretty small number, so like less than 1%, but again, it's happening more than it's happening versus not happening. So just kind of a number to keep in, or a thought to keep in mind that some of our alerts are pushing our users to reprogram. And then looking at the top override, so the top is the quarterly report, so that's the July to the end of September, and then the bottom is the top overrides for October. So you can kind of see it's pretty, the drugs are similar across both subsets of reports, but, and then we'll talk a little bit about what we're doing to fix some of these, but in a little bit, but looking at the October drugs, the first four, so the phenylephrine, levetiracetam, insulin, and propofol are all coming from the adult profile, and then the IV maintenance fluid with the alert of 80 mLs an hour is obviously a PEDS profile. But just interesting to see which drugs are being overridden, and some of them being very high alert drugs. So then looking into the overrides completed in less than 2 seconds. So again, suggesting that the alert is not being read by the user if it's being overridden in less than 2 seconds. You can see that similar drugs that are being overridden overall are appearing in these less than 2 seconds. So really kind of wanting to dive in and see, are we doing the best to optimize our alert fatigue with our patient safety? And we'll talk a little bit about some of the changes that we've made because of this data. And then the last graph shows the high risk overrides. So again, some of the similar offenders are occurring in the high risk overrides, but the high risk is really just the ISMP definition of high risk. So just interesting to see in October which of the high risk drugs are being overridden. So then some of the examples of the changes that we are making because of this CQI data include both propofol and insulin. So propofol has a softmax right now of 83 mics per kg per minute. And a lot of the entries that we were seeing were 999 mLs per hour, which is a very scary number to see. Similar with insulin, the softmax right now is 15 units per hour. And those entries were also 999 units per hour. So looking into the data, we found that there really isn't, or we don't have an insulin or propofol bolus in the library. So users were entering 999 units or mLs per hour to obtain a bolus, and then they would calculate out how long they would need to run the bolus to get the certain bolus that they were, of the dose that they were looking for. So again, a really scary situation, and very easy to fix by just adding a bolus in the library. But without this data, we didn't know that there was a need for this. So we have since then, or we're in the process of fully onboarding a bolus in the insulin and propofol entries in the library, and really continuing to educate the providers on the importance of the library-only entries. Because as you can see with those drugs especially, there's a lot of room for potential error. So then another example with insulin, I mentioned earlier that the softmax was 15 units per hour, and we had entries greater than 15.1 units per hour. So there are about 130 alerts per month that are firing for insulin doses between 15.1 to 20 units per hour. So we presented that to the insulin subcommittee, or insulin music subcommittee group that is looking at evaluating what would be the impact of safety to increasing that alert to 20 units per hour, which would then reduce some of the alerts per month, a pretty significant amount. So, and then two of the other functions, or the other drugs that have been that have prompted changes include piperacillin, tazobactam, and levetiracetam. So the max pump infusion rate that the pump can run in any drug is 999 milliliters per hour. So that then equates to 249.5 milliliters per 15 minutes. So in both of these drugs, they were being, the order was trying to be infused faster than the pump can physically run. So for the levetiracetam, the order was calling for a 250 ml bag to be run in 15 minutes, while the max is 249.5 milliliters per 15 minutes. So the pump was then programming an error, even though it really wasn't an error. But we have since then increased the default infusion time to 16 minutes, which is allowed, the 250 mLs. But without those alerts, we didn't know that, or without the CQI data, we didn't know that these alerts were firing. So we're hoping to reduce some of that alert fatigue with some of these easier fixes. And then another example of the change that we've implemented. So recently there was a patient who was on Velitri receiving the standard large volume bag infusion. They were having a lot of issues with air in the line due to the higher dose and the higher volume being infused, which was then the patient was having significant decompensation when the pump was paused to address the issue. And so this was obviously a big safety concern. And an interdisciplinary group works with CareFusion to figure out what they could do to help this patient. And they recommended using the syringe pump and the tubing, which would then decrease the air in the line issue. because of the smaller volume. But we didn't have a syringe pump entry for Velitri, so the team worked really hard. Obviously, this was a really big safety issue, and so they were able to update the library and push it to the server within 3 hours. And so, as I mentioned earlier, this is not something that would have been able to be done with the old pumps, with the dumb pumps, just because of the nature of the drug library. So this was just a really great example of kind of a quick fix and how our smart pump technology can be easily implemented quicker too. So some of the limitations with the data that we reviewed, the compliance of the guardrail or the use of basic infusion does not specify the location or the specific patient. So without that interoperability piece, we're unable to tell who that patient is and really where they are. And then other than infusion type, so primary, secondary, or drug calculation, we're unable to determine what medications are being run in basic. So without actually being at the bedside, looking at the pump, seeing what's running in basic, you don't know without that interoperability piece. And then also just to note, the data from the training pumps are included in the CQI pump report. So the goals of the CQI review are to use data to modify the drug library limits and potential need for updates, like some of the examples that we've seen. We really want to balance alarm fatigue with patient safety. We've talked numerous times about why that is important and really a driving function of the smart pump usage. And then we really want to enhance guardrail compliance. So that brings us to question 3. Which of the following is true about UVA's current use of medication pumps? A, users can assign patients to specific pumps and update their information or their infusion data directly into the electronic medical record. B, CQI data are currently being reviewed monthly and changes are being implemented as needed. C, basic infusion should only be utilized for users who cannot find appropriate library entries for their ordered medications. And then D, I don't know why these all changed, but discontinued medications cannot be started by pump users. So yeah, B. Basic infusion really should never be used, so just keep that in mind. But and then discontinued medications can potentially be started by pump users. So looking forward to interoperability at UVA, we've kind of talked about this earlier, but the computerized prescribing happens in Epic, which is then verified by pharmacy. The order appears on the MAR and prompts the nurse or the user to obtain the medication. The patient is then scanned with the Alaris pump, and then the user scans the IV medication, then scans the pump. The pump is then auto-programming. The user would then review and push start. And then the information is then auto-documented in Epic, which is then validated by the user. And all of that information is transmitted back into the MAR. So the future of the interoperability alerts. So really, what are the alerts that interoperability will push us to see? The infusion running is not what was ordered. A user overrides an alert, will prompt another alert to really signal, is this really what's supposed to be happening? If a drug is ordered but there's no evidence in the system that it's being infused. If an order is discontinued but the infusion continues to run. And then another feature that will be really therapy specific but really important for some of the IV drugs will be therapy appropriate labs. So IV anticoagulant ordered without the appropriate labs would be an example of that. So there would be an alert to prompt the user to order certain labs, or and then if there are contraindicated labs for future use, there will be there could be an alert that would prompt the holding the next dose of the drug. So really kind of therapy-specific alerts that are able to be implemented with the interoperability. So an example of improvements from another institution in Montana, they found that their pre-population of infusion parameters were reduced manual keystrokes on the pump by 86%. So we talked about going from 21 keystrokes to 3 keystrokes. So that's a really significant decrease. The total monthly pump alerts decreased by 22%. So hopefully we will see similar results as well, and that may further reduce alert fatigue. The number of infusions requiring reprogramming the pump decreased by 19%. Patient identification use on the pump increased from 36% to 81%, which, again, hopefully we'll see similar results because we aren't using that patient identification function as much either. And then they had a reduction in lost charges and increase in revenue. So that brings us to question 4. Which of the following is true about UVA's projected use of interoperability? Users can assign patient-specific pumps and update their infusion data directly into the electronic medical record. Discontinued medications cannot be started by pump users. Decreased use of basic infusion due to integrated electronic medical record and auto-population of the medication order to the pump once scanned. All of the above, yes. So in summary, medication pumps have incorporated changes in safety functions over the last few decades in order to enhance IV medication safety. Continuous quality improvement data provides in-the-moment update on pump usage that may be helpful, optimizing drug libraries and user practices. And then interoperability further enhances IV medication safety by reducing user entries and auto-populating several IT functions. And so with that, I will take any questions.